السلام عليكم جميعا. Thank you very much.
Actor.
Decision.
So
Yeah.
we'll
This,
present something about
no,
CAIRS.
actually, page 19. Before decision. No,
Okay.
it's different. Yes.
So I'm not a moderator.
أنت وراه يعني.
Sorry. Go down.
عادي.
Step down.
So CAIRS
عادي.
is one of the procedures which is
أنت عندك محاضرة
which are
ورا
getting
راسا نروح
some
محاضرة بعدين.
momentum,
لا.
Usually with the CAIRS, planning most of the time it takes much more time than the procedure itself. The procedure is rather quick. So this is a patient in whom, the patient had, Vox trial, advanced keratoconus or severe keratoconus with Vox trial. The vision was not satisfactory for the patient. Usually with the planning, I use the Alfonso classification of the shape of the cone. It's mainly about the shape of the cone itself, where to put the implants and how we fashion the segments themselves. You see it in this type of what we call, I think, the duck type of keratoconus. You will have some inferior steepening, some mark here.
Sorry?
So the segment will be
I
tailored.
have no idea.
Segment will be tailored.
I'm trying to put
according
it,
to
but
the
then I have two, and I'm
thickness.
sure that it will make a sound.
Segment will be tailored to the thickness of the, or to the steepness of the cone itself, in which a full thickness segment will be implanted down, and a partial thickness removal of the implant itself will be done afterwards. So here we are putting the dimensions and the required incisions. Most of the time we do like it depends on the refractive error. Most of the time it's around 4.5 millimeter optical zone to around 7 to 7.5 millimeter. So the tunnel dimensions is around 2.5 to 3 millimeter, and the incision itself is about 1.75 to 1.5. Just a little bit of a drawing of these segments. These segments come, by the way, pre-cut from a vision gift eye bank in the USA. They are called Kira Natural. They have a shelf life. They are sterilized with electron beam irradiation. They have a shelf life of around 2 years. So maintaining a stock of these implants is, rather easy and straightforward. I use the VisioMax 800 for creation of the tunnels. Usually the fixation is very good. The patient can see the green light. It's more or less fixated on the visual axis or the vertex of the cornea. Marking was done beforehand. Okay, so we can just adjust for the a little bit of rotation here. It takes about 5 seconds to create the tunnels, so it's rather a quick thing. I do two opposite incisions at the same time. So once we push the segment into the tunnel, we can pull it from the other side. Here I'll start to mark, the site of partial reduction or partial trephination of the implant itself. So I will know, based on the topography itself, which part will be the thinner part and which part will be kept as a thicker part. By the way, these segments, they do not come like, in very tailored, thickness. So when you have a stock of these segments, you will have some of them around 500 micron thickness, some of them 550, some of them around 600. So you will select the thickness required according to the refractive error the patient has. insertion of these segments, because these are very flexible and pliable, segments. I do not do a lot of drying. Some people, they do drying, they keep them for 45 minutes, or they use heat drying. They can insert them much easier. I do not do this. Most of the time I cannot wait too long. So we're trying to push and railroading these segments into the tunnel by using a McPherson forceps and supporting the segment itself from retracting backward. Once they are in the tunnel, you keep pushing them gradually, piece by piece, until they are like 50% in. Once they are in for more than 50% of the tunnel, you can use a Sinisky, a reverse Sinisky, of course, to pull these segments inside the tunnel. Here there was some resistance because I do not open the tunnel completely using any instrument. I just depend on the laser itself. I just open the beginning of the tunnel. So sometimes there is some adhesion. You have to push strongly to bypass the adhesion, or you can dissect the tunnel completely beforehand. Then using this reverse Sinisky, you can pull the segment to the desired location very gently and very easy without perforating the roof of the tunnel. The roof of the tunnel here in 95% of the cases is around 250 micron. That's why most of the authorities now say these CAIRS implant, they create much more effect than their counterparts PMMA segments because of the rather superficial implantation. So here we are dissecting this end, like 2 millimeters, 3 millimeter in a partial thickness configuration. If there is not much injury for the epithelium, many times we do not need to put a contact lens. If we have a segment which is longer than required, we can cut it. The huge advantage of the CAIRS that we can customize, the segment itself on the fly. You can shorten it, you can make it thinner, you can make it tapered end. It depends on the plan you have. But it's not like, the PMMA rings. You have to have a stock of the required thickness and required arc length for each case. And if you, for example, if you want to customize it, it cannot be done without ordering the necessary sizes. Here you can see the post-operative images of the patient's second day. You can see the implant itself, well positioned, just away, probably away from the visual axis. You can see also the effect of these implants they have. Here on the left, you can see the pre-operative image. On the right, you see the post-operative image, and there is the difference. Down is the difference map. You can see that the effect is dramatic, more than 9 diopters in these areas. And when we section the segment itself along the thickest part, you can see how the segment thins upward. Okay, inferiorly it is thick, upward it is thinner, as was planned more or less in the beginning. Thank you very much.